for the endocrine modules. This will be your endocrine assessment lecture. Again, this is the concentration description, exactly the same one, because again, his diets and concentrations are the ones in your syllabi. These are the three components that we will focus specifically on in the physical diagnosis, the skill technique of it. Thyroid neck exam, diabetic foot exam, and the ankle brachial index. It's hard for me to get out, or ABI as it's commonly referred to. Those are the three things that we want you to show you, and then we want you to practice at. So the diabetic foot exam and the ABI are not listed on your physical exam sheet. Only the neck thyroid is on your physical exam sheet. So here are the lecture objectives. It's always the same for the most part. Please read over them on your own. And again, just note those last 3 bullet points are what we expect. We don't expect you to walk out of here at expert level. That takes practice, just like anything else. Practice on your own time, here, doing it over and over again. We do, however, hope that you understand the components of each one of these and how to do them. The chapters that I always tell you where you can find information in regard to your DeGowan's physical exam book. Chapter 5 has an actual, if you didn't know this, it's under non-regional system and disease, because if you go and look on those book chapters, you're probably like, where is endocrine? It's actually under that heading. Has anybody here actually looked at that chapter by showing their hand up? No one? Yeah, you need to do that. If you click under non-regional, the endocrine section will come up underneath that. It is different in that endocrine disorders, they present across all of the organ systems, in cards, in pulm, in derm, in neurovascular, So it talks about each one of those components. Chapter 7 is head and neck. But again, my lecture is developed from those chapters. So, any questions about that before we go on? Review of systems, I always start with those because they are extremely important in regard to knowing what they are and addressing any student that's like, hey, I don't understand that word, or what's a better way I could ask a patient of that, because you say polyphagia and the patient's like, well, you can't ask them that, right, because we can't use medical terminology in the patients. Of course, you can read over these on your own, and again, they are the exact same review systems that's on your review assistance sheet that's been consistent throughout the year. So these will be the ones that you will need to know for your SPDL. No curveballs there. There's an endocrine metabolic section on your review assistance sheet. And again, the way I always like to look at review assistants, true, a person's not going to come in, so to speak, with a growth and development complaint. They might if it's a pediatric patient, but a lot of these may be a complaint. That's what they're coming in with. That's their chief complaint. That's how you develop your HPI. So like, let's say it was, cold. I'm cold all the time. I feel cold all the time. Okay, yeah, that's your chief complaint. But that's how you need to think about review systems. It will help you wrap your brain around it better. Obviously, some of them are very straightforward, like history of diabetes. And there's only one way you ask that, correct? History of diabetes. Any questions about these? Of course, these are clinical medicine lectures you will get over these different topics in regard to growth and development issues. And then always history of gout, history of diabetes. On your sheet, it just says increased cholesterol, but I put history of. Do you have a history of it? Or, are you currently having issues with increased lipids? It's a good way to ask that. Any questions over the endocrine metabolic ones? Again, these are words that will be presented to you once you get medical conditions. Polyuria, polyphagia, polydipsia, those are going to be with your diabetes, clin med lectures. Hair growth patterns, those are going along with some of your thyroid disorders and adrenal gland disorders. So review of systems for the neck, they're listed there. Swelling, lumps, goiters, pain, and then limitation of movement. Those are the 5 ones that are listed. What I have typed under there is hopefully a way to kind of help you understand how you ask a follow-up question if they were to say yes. Because that's kind of half the battle, right? There's nothing worse when the patient says yes to it and you're like, no idea where to go with this. Thank you for telling me. But eventually, you'll build on your, that's why we do what we did. It's when we take you through the different modules. You'll be able to say, okay, so you're having some dizziness, do you? And you can follow up questions to piece that out better. But I try to write as much as I can out for you to kind of help you understand that. Things that you can ask to get more information. So again, if they report swelling in the neck, and some of these are not too far off from your Big 8, because again, it's difficult to develop an HPI. Your Big 8 is a really good generalized way to just approach it every time. So, location, character, pain, obviously if they have neck or thyroid pain, you can definitely use your Big 8 for that. Limitation of movements, I don't want you to get too caught up in some of those details like fever or illness. You're like, well, what would that mean? Once you get a thyroid lecture in regard to some of your thyroiditis issues that go on with your thyroid, you'll understand that they can be secondary to a previous viral illness that they have. So if people have issues with their thyroid because of pain, you say, you didn't by any chance a couple of weeks ago, in the last 2 months, have a viral illness or a respiratory cold or something along those lines, because it can help you understand that could be a potential that you now have inflammation of the thyroid. Does that make sense? I know it does. I don't want to harp on it too long. I just want you to understand that half the battle is getting information from a patient. You'll be able to, sometimes at the end of your HPI, have them diagnosed if you could. So you have to know what to ask. This module, and again, because you're going through each of them now, so they will start building on to each other. You'll need to pull from other ones. But this module, endocrine, is one of the ones, I think Durham's probably another one, that can be across all the other organ systems. They can have symptoms that go through the CARDS, the palm, the derm, the psychiatric. And I know you haven't gotten some of these courses. I know you haven't had GI. I know you haven't had psych. I get that. I'm sorry, you actually have had psych, correct? Oh, I'm sorry. I thought that was what your geriatric, so I apologize. I understand that, but just be aware that you need to go through some of these other systems. And the point I want to make there is a reason we make you try to memorize them and recite them as much as possible, because the more you do it, the easier it will get for you. And you will have instances where you'll have a patient who presents with fatigue. That's extremely, God knows, a lot of different things. You will have to pull from your other organ systems. Does that make sense? And once you get to the end of this, if you were to go back and pull up that review of systems, you will look at all those and know what endocrinopathy or what endocrine disorder that's associated with. You'll say, oh yeah, now I get it. So hypothyroidism is changes in hair and nail texture, cold intolerance, weight gain, constipation, all those things that you see sprinkled throughout. That's across all of your endocrinopathies or endocrine disorders. On eyes, I know that kind of sounds funky, eye appearance. What I mean by that is the patient came to you and said, God, I feel like my eyes are like protruding more, hanging out more. That's indicative of one of your thyroid issues you'll get to later on. I have it already, so. Any questions over that? Okay, good. So, part of your medical, or eliciting and obtaining a proper medical history is, again, your HPI. It is, your bread and butter, it's where it's all at, in my opinion. So I gave you an example of one. So a patient would present with a chief complaint of fatigue, which again makes most people shiver when they hear that. They're like dizziness, fatigue, those are like the two that you're like, I love them though, love them. Because there's so many things that can cause those, and you really get to show out and be like, here's all the things that can cause this, and this is what I'm gonna do for you. So these are some of the questions that you would wanna ask. I could have chosen any chief complaint for your endocrine assessment. This is just an example. But again, these are ways that you can develop that story, put those pieces of that puzzle together to get your big picture. This is just an example. We all know the additional components of the medical record. You can review them there. Of course, dietary nutrition assessment, physical activity, tobacco, alcohol, drug. Those could be separate if you wanted to, or you could again put those in your social box, your social history box if you wanted to. I teach you from here the big boxes, but just know when you get out, you can write it any way you need to write it. But physical activity, diet, nutrition assessment, those are important for your endocrine course. They are very important, especially if you're dealing with weight gain, weight loss, those types of things. Fatigue is actually, it's extremely important to ask about those types of things. Medication history is obviously very important, always. And then I add in psychological status in the endocrine course. Not that it's not important in other courses. It's important here because some of your endocrinopathies can present with anxiety, depression, mood changes, labile mood. So it is important to get a feel for that. Any questions over the different components? I know you've seen this a gazillion times, so that would be your subjective information, correct? Okay. Any questions? Anything? So we'll start with the physical exam portion of the neck and thyroid. It's mainly your thyroid. You know, you're not doing a whole lot with, per se, the neck, because there are a lot of structures that make up the neck. But we say neck because you're actually also looking at the trachea, which is on thyroid. So that's why we say neck and thyroid. And in most literature, you'll see it presented that way, neck and thyroid. These are the three components that are on your phys-die sheet: inspection and tooth palpations. There's actually a fourth component. If you think someone has a goiter, we'll get to that in a couple of slides, and that would be auscultation. You can actually auscultate the thyroid, and there's a slide on that. It's just not on your phys-die sheet. It could be added on as a special test. It's one of those things that if you get a positive upstream, you need to do this downstream. That makes sense? So inspection, you're just looking for symmetry, any type of masses that are sticking out, tracheal deviation, because if you have the trachea anatomically, you have something kind of big that's growing and getting bigger, it is eventually kind of like your tension pneumo, if you remember that. It's going to just start pushing it to the side. You always want to view the patient from, the front of it, but then you also want to go to each side and look as well. Because if you have something that you're trying to look at for one, you do need to go look at each side of it. It's kind of like when we looked at the chest for excursion, you went to the side of the chest and the other side of the chest to try to get a view of it to make sure. Does that make sense? You do need to verbalize this. And make sure I wrote these out this time. Does it mean if you're in your SP, PDL, and you don't list off those three things? No, we don't. It's just, again, a way of making you put your mind into that way of thinking. you need to verbalize things, not only for yourself as a provider, because you'll memorize it 1,000 times more, but then also just to your patient. You know, I don't see anything that's concerning. I don't see any masses. Just use the word mass with the patient. I can tell you what that means. Because they kind of learn, some people do. Some people don't, but most people, when you're doing your exam, it's totally cool to kind of tell them what this is what I'm looking at now, or this is what I'm going to go do now, or they like that. It's good communication with your patient. It gives them a heads up too. So verbalize what you're looking at. Palpation, you're palpating the thyroid, and you're going to be palpating the trachea. In regard to the thyroid, there are two approaches to it. There's the anterior or frontal approach, and then there's the posterior or back approach that you can do. You need to do both. If I said or, I apologize. It's front and back. And that is because of you can palpate things better in certain ways of being in relation to the patient in your actual hands and thumbs from the back and into the front. You can. You're going to ask the patient to swallow in a couple of slides. I'll better explain why that is. It's just to see if that thing moves and that you can feel it move. And then the third bullet is palpate the trachea on both sides and gently. You don't want to get too crazy because that doesn't feel too good. It doesn't go very far. You just want to make sure that it moves ever so slightly. You don't want it to be adhered. So that's why we do that. And you start inferiorly and you work your way up. And if you think about anatomy, you think about what's connected and where it's placed, and then you also thought about a pathologic process, a mass or a tumor or something funky growing over there, you can understand why the trachea might not move. That there would be reasons for that. But if you think about it that way, it makes it so much easier to keep in your mind. Does that make sense? So anatomy, it is important. Again, I say this with a puncture. It is important to know where your anatomy's at, where it's located. How can you palpate and comment on something if you have no idea what you're even touching? Because again, we do have a barrier of skin and fat, muscles, and all kinds of stuff that keeps us from seeing it. So you do need to be aware. So just take a look at this for a second. And remember, most thyroid glands should have two lobes. There's they call them lateral lobe, but there should be two. The anterior triangle is an important anatomical location for this part of the physical exam because, again, if you do the medial border of the sternocleidomastoid and that line of the mandible, that's where you're working. That's where you know you need to be. You're not going to be back here. You're going to be in that area. The content of the anterior triangle is also listed right there for you. Not that you can't palpate the posterior triangle, but you do need to be located properly for the thyroid in the anterior portion. So we're kind of repeating some stuff here, but again, I think it's really important to, you shouldn't ask a student or any medical provider to tell you what an abnormal size is when you don't even really know what the normal size is. What is that really supposed to be? How big is that supposed to be? So this is just some information in regard to, so each lateral lobe of the thyroid should roundabout be about that size, 4 to 5 centimeters long, which is really tiny if you pull out your Maxwell's and you measure out how big 4 centimeters is. It's so small. And I may have written this somewhere in your notes section, but for the most part, you're probably not going to be able, you should not be able to feel an adult's thyroid. It's kind of like when we were doing the pelvic exam and you were trying to capture the uterus and capture the ovaries, and you're just like, oh, dang it, I gotta touch, I gotta capture this, why am I not? It's okay. It's okay that you didn't. Sometimes not is a good thing, because it doesn't mean it's enlarged. Does that make sense? It's when it's big and has a tumor or a mass or a fibroid or a growth that you're like, oh yeah, really, I feel that. You shouldn't feel most adult thyroids. Everybody's already starting to try to palpate theirs. I did it too all day. I was like, wait a minute. Do you remember seeing the thyroid gland in your cadaver? Anybody have any weird anatomical, like a remnant? I know there's what was yours?
I just remember on the exam, like one of the things was there's like the pyramid portion of it, like it was lobes on each side, but there was also a middle portion, the isthmus, I guess.
Okay. Like sometimes they'll have what's called and I'm probably not saying this, so Professor Brooks or Dr. Latassi tell me. It's like a remnant, like you can actually find it in the chest of it, like that was, I haven't ever had that. It was like a long portion of it. Anyway, there's some
Most of the time, once they do a thyroidectomy, they do leave a remnant of that tissue in there. You
So
don't
it's
always
secrete.
leave it, take it out completely. There's always a small remnant of tissue.
So again, these are measurements, that is your guidelines when you go to actually palpate. You can kind of understand what you're shooting for. But again, everybody's different anatomically. So this is just a picture of kind of anatomically, again, what you're looking at, what you're dealing with. So now we're going to go to the actual inspection. Yes, ma'am, yes.
Can you point to where exactly in your neck you would palpate is it like,
I'm listening to you.
Right here.
where would you typically, where here?
It's in this, like, you're getting ahead of me.
Oh, okay. I was trying to visualize it.
Essentially, the way I mean it, without even looking at the slide, I always do it where I start, I feel for the biggest piece of your, I want to say Adam's apple. I know that's not, I don't think I have. But you can feel an area that's more prominent. Do you feel that? Like if you took your finger and go up and down your, if you ever not felt that, there's a little area that's a little bit more prominent. The way I do is I put my finger on that and I go substernal notch, and I know that it has to be in between those two areas. I mean, because everybody's different. You'll get people with very short, odd necks, very large necks, so that that is between here and here is where I'm going. So those are the first two things I'll do. I'll stick my finger on it, feel for it first. Put my finger there, and then just kind of know that is what I'm aiming for. And then let me get it, and I'll talk to you through it. Because again, I know on the slides, it's so technical. Basically, there's just, you settle down, you go over to one side of the field, you go over to one side of the field. So I try not to just read directly from my slides. Professor Brooks will come down here, and I'll do it on her. She can do it on me or whatever. She did a lot of thyroid neck examinations in her head and neck onc job. So that's a good question. That's a good question. That's just where you're shooting for. That's the wrong computer. Why is it not changing? Okay, so, okay, come down here, Nikki, actually. Any questions so far? Don't be afraid. Every question is good. How about you sit? Yeah, come out to the side here. This slide here, this slide, but then also speak. So what we'll do is I'll show, and then you can break up and practice on each other. Okay, so before we even touch, we always inspect. And we're going to have the patient obviously sit upright in a chair to do this because you want to get a full view of both on the anterior and the lateral side. Obviously, you need to have good cross-slot or, and if you wanted to, what you could do, if you really wanted to look, come in on the lateral side, or the side of her, you could take your headlamp or your light, most rooms will have it to do your gyne exam. You can stick it on the opposite side, and it just helps you create like a little shadow. Helps you create a better profile of it. Does that make sense? If you don't have one of those, it's okay. You can just do it along, without the light. You want to inspect the lower half of the neck in the anterior triangles. You're going to look for symmetry, and you're going to look for masses, and you're going to look for tracheal position to see if it is pushing off to the side or, for the most part, in a straight line area. And basically, you start in the front and go then, because that way you can get a good just head-on view of what the front looks like before you go and compare. You do need to do both sides because you got to compare both sides. So again, it's really simple, just like this one. You just stand in front, and again, this is just inspection, you don't have to touch anything. If their collar is impeding your view, have them take it down. And just have the patient, you don't want them down like this, or, make sure you can get a good view, and if you have to do that, because sometimes you have to guide your patient and tell them what to do for positioning. I always just have patients, I'll say, would you pick a point on that wall, like the soap dispenser, and just take a look at that for me. And then that way they'll raise their head up, or you can, help them up a little bit. Again, so you just look at the front, and I'm just going to, and again, you're just looking for symmetry. You're noting just gross masses, golf ball size lesion, redness of the skin. You're just noting. And then you're going to come over to the side. And then you're going to come over. And again, just inspect both anterior and both sides. Does that make sense? I'm just reading this. The neck, you want to note that it looks symmetric on both sides. If you had to draw it or think about it again in quadrants, I know again you're using your anterior triangle as your point, your area that you're looking at. But if you want to put it into, this is my quadrant, this is a quadrant, and this is a quadrant, that you can do that, mentally, that's what you're looking at, and you just want to compare. You should see, or should in your mind, draw a straight line down to the substernal notch. Right there. And everything, trachea should be in that straight line for the most part. Now, are there instances where people's neck is fluffy? And you may not see the trachea, you may not see anything? Absolutely. Yeah. But again, you just note that. You're just looking for gross deviations. Okay?
And you'll see it, if you
Yeah,
ever
jump
see a
in.
goiter, which is basically an enlarged thyroid lobe, it will deviate their trachea. You'll see it, and they'll have a big mass on one side, and they'll shove it to the right. A lot of them come in complaining of shortness of breath or wheezing, because it also can press on their laryngeal nerve.
Which causes, what would it cause you to potentially have if it wasn't? What is it?
Hoarseness.
Yeah, absolutely. We also need to think mediastinal mass or cancer. Somebody who comes in with just random hoarseness. Okay. So, trachea symmetric, neck symmetric, no masses noted, trachea midline, or trachea not deviate. That'd be a normal way to say that in your note. This is showing you a breakdown of the side view when you come in and look, and the things that can help you if your patient, if you're able to do that, if they're not thick through their neck, that can actually help you when you're looking at the neck. So the laryngeal prominence, the cricoid cartilage, and so basically, again, where I told you cricoid and substernal notch, that should be that straight line. You shouldn't see anything funky popping out of that.
patients, like that picture there, some will come with goiters that are that big, but a lot of times, some people don't notice it until they turn their neck and you'll really see it bulge. And then we do a CAT scan or they've been told they had a thyroid nodule like years ago and they never had it followed up, and then 20 years later, they see us because they start experiencing some have no symptom, but other than a big bulge when they turn their neck. We do a CAT scan and they actually can go down below substernal, and then they used to have, I've had 2 patients where we had to crack the chest open because they couldn't get the thyroid gland out through their neck incision. So they have it's painful, that's worse than up here. So they have a scar here, and then a scar going down this way to crack open that to get to their thyroid gland, because it grows down instead of out, so that can happen too. So something you think is a small mass or a small goiter is actually larger because it goes back, pushes against their trachea, and then it goes down too.
So the last component when you're doing your inspection is you can have your patient swallow. And there's different ways you can do it. You can have them just swallow what they have. Sometimes it's hard, especially when you're nervous or you have to do it on demand. So you can get your patient a little cup of water to just say, take a sip and swallow for me. Again, you want to have them still in the same seated position as you had for the other inspection. But this way you just have them straight on, take a drink, swallow. And essentially, the trachea and the thyroid, because there are some ligaments, they should, for the most part, rise and move together and then descend back down. Observation during swallowing helps distinguish thyroid tissue from other neck structures. So essentially, when they swallow, and when you go to palpate them, you'll also make them swallow, and you can feel it, you should feel it. But when you're inspecting it, you would want to look straight on. I do it straight on. I don't do it side to side swallow. I only do one swallow with them straight on. And I just have them swallow, and I just watch swallow them. You can barely see it, and when you break into groups, you'll obviously get to practice more and see it. But they should rise up together, pause ever so slightly, and then descend back down. This is really important if you were to see like a mass on gross inspection, and you're like, I don't know, is that part of the thyroid? Is that just a lipoma? Is that attached to your skeleton, the muscle underneath? Where is that? Obviously, if it stays where it's at, and does that make sense? The thyroid should bump up, go back down. So if it stays where it's at and that's doing that, you know they're not related or attached for the most part. 1, 2, and 3 actually give you some things to help you in determining if the neck mass is probably, if it's not in the thyroid, one of these will be seen or detected when you make them swallow. But essentially, if you were to see a mass, and you do this to determine if it's attached or not to the thyroid or the trachea. Okay. So now the actual palpation portion of it. There's both the anterior and posterior approach, or the coming in from the front or coming in from the behind. It's that way in your book, that's what it says in your book. And again, when you're palpating, much like the cervix and the vaginal wall when we did the pelvic exam, a lot of times you're, as a student, obviously, you're nervous, you're just getting in there and doing the motions. But you do need to be mindful of what you're actually visualizing or palpating, because you do have to document that later on. So these are the things that you should be looking at. Thyroid size, is it enlarged? Consistency, is it soft, firm, rubbery? Is it bumpy, gritty? Are there nodules? Are there masses? Obviously pain. If you go to palpate it, it hurts them. That's obviously a problem as well. And then obviously when you go to palpate and if you feel that there is tracheal deviation or that it's off, you would note that as well. So these are the things you're going to want to pay attention to when you do the physical exam. Jump in. Are you going to say something? So, palpation from behind. So essentially, and this is again, in regard to good patient communication, making them feel comfortable, you can kind of tell them, now I'm going to actually feel your neck and your thyroid. I'm going to do it once with me standing behind you and then me in the front. Because patients can get a little nervous if you're back there. Always be verbalizing where you're going to be at in relation to the patient. And again, I've told you guys this, when I move around a patient, whether it's front, back, or side to side, I try to keep a hand on them when I move in the back. Just to, I don't know, I was taught that, just to let them know where I'm at. You will need to free up your hands, obviously, to do the exam, but when you're moving about, you can do that. So we'll start from behind. Place yourself behind the seated patient. Again, they are going to be seated. Lower their chin to relax the neck muscles, much like we said in inspection. You don't want to, you want to, have them straight on it first. Place your thumbs in back of the neck, curling your fingers anteriorly, so long and ring fingers, tips just touch while resting over the upper tracheal rings. So again, if you know anatomically, this is where you're working at. You don't have to be up in this neck of the woods. You can feel and know that that's where you're kind of going to go with your fingers. And I'll do the movements here. It's so hard for me to like read and do it. So, okay. So I'm going to lower my chin to relax the neck muscles. Why I can't say that. Place your thumbs in the back of the neck. She has one there. Curling your fingers anteriorly, so the long and the ring finger just touch while resting over the upper tracheal rings. Have the patient hold some more. They're going to have that there when you need to swallow. I do that last though. Locate the cricoid cartilage. She just located the tracheal ring, and then if you move down or inferior, the thyroid should be. It's like someone's strangling me. I'm trying to talk. It's like it's just a weird sensation. You're fine. But again, because I have been trying to help, I can't feel mine. I can't feel mine. But you know that's where you're starting and you're going down. The lateral lobes on obviously either side of the trachea and will rise under your fingers during the swallow. Basically, you're feeling for tissue overlying the tracheal rings. It's likely, if you feel something there is can be some hyperplastic isthmus tissue, which is fine. But you palpate systematically to the lower poles on both lobes, so left or right. It doesn't matter which one you do first, or if you want to do them together. I do one, and then I feel them both at the same time to compare. Palpate the anterior surface of each lateral lobe through the start, so you know you shouldn't be going past, you can feel your SEM, you can feel it, it's right, she's got it, grabbing it. You don't want to go behind that. I mean, you don't want to go behind that.
I'll be here looking for a thyroid.
Right, you're going to be in that anterior triangle, right? Yeah. With the patient's head slightly inclined towards the side being examined, and you do that to loosen up stuff, because once you do this, that strap muscle loosens up and you can really get in there and palpate. During the examination, shift the head to relax the neck muscles and have the patient swallow again to test for, once you've palpated both lobes, you've palpated it, then I would swallow as she's actually holding it to see. Ooh, that's hard. But again, if it's a normal thyroid, you're not going to have, I don't want you to think you're going to feel this big, oh my God, it's tiny. You're likely not going to feel it, and that's a good thing. There's not a mass there, it's not enlarged. So you just loosen up if you want to test that. Does that make sense? Loosen up the neck, palpate, if you can. My neck's actually pretty loose. And then just go over to the other side in order to dig in there and get in there if you need to.
And you can push her trachea too. That's why I usually push it over. And you can really feel the sides. Push the other way.
I think that's on that anterior approach. Do you push the trachea both anterior and posterior?
I only do posterior, I don't do anterior.
Okay, okay. So did you see that? And again, we'll walk around and show you what you're doing with your fingers and whatnot.
It's easier in men because you can find their cricoid cartilage because they've got the Adam's apple. So it's the edge from below that. And it should be like maybe 2 fingers down, you'll feel the cricoid cartilage. And down below the cricoid cartilage will be the first and second vertebrae. or rings of the trachea, I'm sorry, rings of the trachea, vertebrae, rings of the trachea.
That doesn't bad calls. Who cares about thyroid? So, you know, and the craziest thing, when I was taught, I don't want to say this, we were always taught anterior approach. It wasn't until later on that I was in practice that I actually saw some of the MDs who did the posterior approach that came from behind. But,
Yeah, I mean, you'd be amazed how many people like think that they, because you know, it's a misnomer, because it's the thyroid cartilage, so most people think your thyroid is
Right.
up here, but it's actually not.
It's low.
It's low.
Again, I know it, I do sternal notch, cricoid cartilage, and I know it's gotta be in that area, and I just work my way down inferiorly in that area to feel for it.
Now, some people may have a thyroid cartilage that sits up a little bit higher, so you can find that little variation, but you can feel hers right there. Just step down.
In the anterior approach, it's essentially what she just said in regard to you use your thumb, whatever finger you feel most comfortable with, to push the trachea to the side. But you could obviously do it from the posterior as well to get in there. Don't you scare me. I guess I'm the wrong thing. I'm just looking here.
Professor Brooks, you're pushing like not super hard, but it seems like you're pushing like pretty hard, right? To build masses here?
Well, yeah, I mean, like, some people, you can really feel their thyroid if they have a large thyroid, but I think I'm just used to it because that's all I'm looking for are masses. But like, her bubble just went through there when she swallowed and I could feel it. But you really just gotta get in there and feel, because some people who are skinny, you can actually feel their thyroid nodule. If they have a big nodule in the skinny neck. Okay, swallow for me. Oh, I felt that bubble.
That was hard.
Sorry.
But bullet point 3 and 4 is technically what the technique that she is doing. It's reversed. Instead of thumbs being on the back of the neck, you know, now you're coming around and thumb is in the front and the fingers are wrapping around the back of the neck. And again, we'll walk around and work with on this. So when you do it, do you feel at the same time, or do you do one lobe, and then compare? That's the way I do it. Because again, I just want to,
I usually do both, like I'll put my fingers on them both, and then I feel, because I've always been taught, you know, to do it at the same time. But then I will push and feel one side, push, feel one side, and then just kind of go back up and down it, and then have them swallow. Because on a thyroglossal duct cyst, that would stay still. So you would know it is not in the thyroid. It wouldn't be a goiter or something. So it won't move up and down with the trachea. But those are often mistaken as the brachial cleft cyst or thyroglossal, and it's actually a tumor.
but again, we will expect you to do anterior and posterior approach for that, okay? It's a good habit to get into. And again, I mean, you can read a book and do a PowerPoint, but it's all about, it's just, you gotta get in there and put your hands on it and actually try to palpate the lobe. Or be at least in the correct location of where that lobe is located. Let me go to this.
So you guys haven't gotten hyperthyroid yet, have you?
We haven't done
That's
any
always
thyroid.
good. When you're behind them, you can actually look or to the side of them. You can look at their eyes to see if they have bulging of their eyes at that time too. You can actually measure, there's a little measurement thing.
To look for
Exophthalmos.
This is a picture that's from your book. It's after each slide. It's the same picture. It's essentially just the first picture is showing you finger placement from behind as where the B image is where you're doing it from the front. Much like the slide that I told you that you need to note, these are just telling you kind of what the normal should be for the most part. They should be, you know, firm but not hard, smooth. And you can actually, you know, once you get in there, like the breast tissue, you can move it back and forth and it should be smooth. You shouldn't feel bumps, gritty sand, paper feel, hard nodules. It should be a smooth feel. And then also there's the tracheal alignment, you palpate it. You're basically going to place your thumb along each side of the trachea in the lower portion of the neck, and then just work your way up just to feel. So again, I start inferior for this at the substernal notch. I find the trachea, I place both fingers on it, and I just palpate.
Fun. I would do.
And you should. And again, you just work up. You use your thumb placement on each side to kind of help you gauge for symmetry. So if one is this and the other one, your thumb's way out here, you know that's not symmetric. And again, you just move up. And as I do it, I just kind of slightly, not, you don't want to choke them or whatever, just move it ever so slightly back and forth to make sure it will move, that it's not completely adhered to anything. And again, start inferiorly, work your way up. I have on here, let's practice, because we're going to then do ABI, but what we'll do is, why don't you take a, well, no, it's just 3:36. People were getting up, so I thought they were needing a bathroom break. Let's just go on, we'll go through the ABI, because you've actually already been given ABI somewhat, so this should be fairly quick. And then we'll break up into groups and we'll practice doing the thyroid, and you can ask any and all questions. Okay? Oh, auscultation of the goiter. You're going to use the bell for that. And again, if you did locate an enlargement or thought they had a goiter, you would take the bell, much like you would do when you auscultated the carotid. You would place it over the area that's enlarged or that you're concerned about for possible goiter, and you would just auscultate to see if you could heard that swishing, irregular, turbulent blood flow. And the reason for that is, I know you haven't had goiter yet, because it's an enlargement. A lot of times in the body, when anything enlarges, whether it's a tumor, mass, whatever, it can have increased vasculature to it. It's growing, right? So it's going to be supplied. So what happens is this increased vasculature that shouldn't be there. You can actually hear it with the bell. So you don't have to worry about that in regard to like the carotid. I'm not going to drill into your head. Always auscultate the carotid before you palpate because of the you don't want to throw a clot. You don't have to worry about that with the thyroid. You can, if you palpate the thyroid and then auscultate it, you'd be okay. Just want to throw that in there. So again, auscultation of the goiter would be your special test. If you thought you felt something, then you would do that. You don't have to do that every time on a focused thyroid neck exam. If you did have a goiter, there's a little kind of, it's called the rule of thumb that you can utilize, because again, half the battle for physical diagnosis is not just being able to do it, but also document it, right? You have to put something on paper that the next person that picks up your note can read and understand and get a feel for. Whether it's a referral, you referred them, or if you have them on treatment and you want to see if the treatment's working, then you'll look back at your own note, make sure you measure so you can determine if it's progression of disease. That's why we try to document or measure things as much as you possibly can. Sometimes it's hard though. A rule of thumb, if you do have a goiter, is that it states that the lateral lobe is enlarged if it's larger than the distal phalanx of the patient's thumb. And again, everybody's thumb's different, I know that. That's kind of the rule of thumb that you utilize. No pun intended. So when you're in there, and let's say you localize it to one of the lobes, and you're like, that feels enlarged compared to the other. I'm going to try to get a measurement or a feel for that. You can actually, so you can take your, take the thumb, you can measure it out. So you would do the length, so the length of it, the width, so the top to the bottom, and then you can actually do the depth of it. That's a skill. That's if you were to, let's say the lobe was thickened, you could feel going back to see how thickened it had gotten. Does that make sense? You can estimate it by doing this calculation, and it can basically give you an idea of the volume or mils, volume of the thyroid. If you didn't do this, you would not be in trouble. Now, if you were in endocrinology or something on a subspecialty, you would really need to know to do this. But it's not a common thing that I've actually seen in a family medicine or primary care unit. So if you were to measure, anything greater than 20 mils is classified as a goiter. So an example, if you were to take your, try to measure out, take your thumb up one of the lobes, if it was 3 centimeters wide, so if you had a lobe, this is a portable drawing. So this is the width, I'm sorry, this is the width, correct? So you measure the width, and then the length of it is obviously how, I made it kind of short, I should have done that. The length of it, and then the depth of it, if you were looking on the top, would be if it was wider. Thickened. Does that make sense? So if you got those 3 measurements, 3 centimeters, 2 centimeters deep, 5 centimeters long, you can multiply those, it comes up to 30, that would be roughly 30 mils, which is over 20. If it was both lobes, you would have to measure both lobes and do it, and come up with a number. Nikki, have you ever seen anybody ever do that measurement like that? It would be very subjective, it'd be skill and technique of actually feeling it enough to be able to do it.
A lot of the goiters are measured by ultrasound.
Ultrasound. But, if you ever had one, don't be afraid to practice your skills on it. You can do it. They will, of course, do it. You get an ultrasound on measure. It doesn't hurt.
I wish I had pictures of patients, I mean, I took pictures of everything else, but I didn't, we had tons of goiters that come in that were big. But a lot of them, like I said, some of them were just big, but you had to turn their head. But the one lady I was thinking of that had a big goiter, it's actually just a giant lipoma, it was huge. It was all underneath her neck, and it was crazy, but the goiters can look like that too.
Any questions over that? It's just a little measurement tool you can utilize. Thyroid nodules, this is something that you might potentially pick up on physical exam. These are just some facts for girls to be aware of. They're more common in women. Most of the time they're just discovered just randomly, unless a patient actually came in with that complaint, like, yeah, it looks hot on my thyroid or my neck. Most nodules are not palpable. The mean diameter of one is 3 centimeters, which again is tiny, it's so small, it's just so small. You don't realize this until you pull out your Maxwell's and measure out 3 centimeters with your finger. It's so tiny. The most important diagnostic test, which I know this is not what this lecture is about, is I don't want you to think though that physical exam is the end all be all. You're obviously going to pick something up on physical exam that's concerning. You'll test it out with other things. You'll do imaging, you'll do biopsies. Because in the pelvic exam, someone had a great question about that. They were like, well, what if you're doing your bimanual and you were trying to capture the ovaries and you just didn't feel anything, but you're still worried? You just let that go? And I'm like, no. So this would be an example. If they were coming in with a complaint that led you in that area, and the clinical picture had other things that were concerning, you could say, I don't feel anything, I don't feel anything, but let's go ahead and order an ultrasound, or let's go ahead, whatever. Does that make sense? Don't ever be afraid just because you didn't feel it on physical exam. You can do other, you can work it over other ways. Those are just facts that you can read on your own, because again, that's not what this lecture is about. These are some physical exam findings that are specific for some of the endocrinopathies. You will get these also in your lectures on these ClinMed topics, because I think the thyroid disorders have some of the weird, actually endocrine disorders in general have some of the weirdest physical exam presentation signs, I guess signs is a better word, than I would say majority, other than your genetic type stuff. There's some really weird stuff that comes out with endocrinopathies, whether it's the thyroid, the adrenal glands, the weirdest one I think. It's got pituitary, they present in many different ways. And those will be pointed out in those specific lectures. I'll give you your adrenal gland and pituitary, and I'll talk about that there. This is total sidebar, but I did not realize until last year when I did the adrenal gland lecture that JFK, I'm gonna totally give this away, John F. Kennedy, President JFK, he was always dark. Like if you ever, now you go back and look, you're like, I never even noticed that. He always had a tan, he was always a very dark man. Now granted, they were always out in the sun or whatever, but he was always darker than most people around him. He had an adrenal gland issue that made him more pigmented than other people. And I just never knew that about that. And again, after you find that out, you look back through history and you're like, he really was darker than most people. But again, it's just a funky physical exam finding. And like Nikki was saying, eye changes, derm changes. You get a derm lecture, dermatological manifestations of endocrinopathies. It's a really neat lecture. So anyway, look over these. These are just some of the ones. Non-pinning edema, issues with low thyroid. They can have a yellow tint to the skin. And that's because of increased keratin levels in the blood. And again, this lecture is not about the physiology or pathophysiology of these diseases. It's just some of the physical exam findings that could be consistent with these diseases. They can have coolness to the skin, dryness. People with hypothyroidism will often have dry, flaky, scaly-looking skin. And again, a lot of funkiness is going on in regard to their hormone levels that cause the changes that you will see. They have issues in regard to their reflexes. So this is an important reason why we do check reflexes. They will be delayed. Hypothyroidism, if you really just think about the most general way, it slows everything down. It's just like as where hyperthyroidism speeds everything up. So hyper, they have a brisk ankle reflex, Achilles reflex. It's kind of neat. Hyperthyroid, so increased levels. Lid lag, lid retraction. They will often have they'll be tachycardic because again, they're basically everything in their metabolic processes is sped up. It's going fast. It's going overtime. So they will be tachycardic. They have, instead of cold, dry, they are a warm, moist, kind of tacky feel to their skin because they have an overproduction of that sebum. They also have what's called pretibial myxedema. Do not be confused on this because there are other, there's myxedema coma. It's an endocrinopathy type emergency, totally different thing. Pretibial myxedema is a physical exam finding that's consistent with hyperthyroidism. It's on both legs. It can be asymmetrical, doesn't have to be exactly looking the same, but it's on both lower legs. You won't just see it on one leg. If you see it on one leg, you need to be going down a different route as to what it is. They'll have plaques or nodules on their skin, and it can be like a pink, purple, brownish color on the anterior shin. That's usually where it's located. And again, it's called pretibial myxedema. So those are just some fun physical exam findings consistent with those disease states. Okay. Last but not least, let's just go through this. And if you want to take a little bathroom break, if you want, you can, and then we'll come back and we can practice. How's that sound? Cool. So ABI, you were briefly introduced this in your card section, the cardiovascular section, in particular in your peripheral arterial disease lecture that I gave. It is an exam that you can do that is cheap. There's no money involved in it. You have to go order something. You don't have to expose a patient to radiation. Takes only a couple of minutes if you're good, if you can get a good system of doing it. And you can do it in your family medicine office, primary care, you can do it pretty much anywhere if you have the necessary tools. Dr. Latassi was telling me that they do it also, there's a machine that will actually do it as well, which, there's machines that take blood pressure, so again, it's important to understand how to do it, because you may be somewhere that doesn't have that machine, and you may have one of your preceptors come to you, especially in the cardiovascular or your cath lab rotation and say, hey, I want you to go back